I'm Llewellyn King, the host of MECFS Alert. Welcome to the broadcast. I'm glad to have as my guest today Ryan Pryor, who has been on the show in the past, but quite a few years past. 9 years, I think, was the last time we had the pleasure of his company. Ryan, welcome to the broadcast. How are you?
Thank you so much for having me. Yeah, I'm doing great.
Now, you are an MECFS patient. You've suffered for a very long time now. How long have you had ME?
I think I was diagnosed in 2007, so about 15 years ago.
And but you're functioning. You have an assignment at CNN, and you've just written a book, which is what we want to talk about today.
Yeah, I've been doing mostly recovered at this point, and yeah, I was able to work at CNN for a lot of the last 6 years or so before I started working on this book.
Tell me about the book. Is this about your own experience, or is it about the totality of the community suffering ME and the hopes, the medical hopes for it?
Yeah, it's a book about COVID long haulers and how people with long COVID are essentially changing the future of the healthcare system. And so I was a features reporter for working for the CNN science and health teams during the pandemic, and was fortunate enough to get a book deal to write a longer full-length book about long COVID. And so MECFS, myalgic encephalomyelitis, is a component of about half of long haulers probably experience a form of MECFS symptoms. So there's part of my story, personal story, is included in the book, but it's largely about the kind of the U.S. or the international experience of.
And what have we learned about long haul? I just did a very interesting interview with Kenneth Friedman, who is looking at a variety of diseases which have a moment of insult, a time of sickness, followed with symptoms that go on and on and on, and which look remarkably like ME, but are not ME. One of them is long haul, another is Lyme disease. There are some others. What are we learning? What are we learning from long haul? We know it's a lot better financed than ME ever has been.
Mm-hmm. Correct. Yeah. There is some funding available for long COVID in ways that MECFS has not experienced, but yeah, a lot of the profiling of symptoms post Lyme, post COVID can mirror each other with the number. If you draw out bar graphs, and the same number of people might have fatigue or brain fog, and then pain, sleep disturbances, on down the list. So I think the larger way to discuss Lyme and COVID and MECFS is in this context of immune-associated chronic diseases, of which there's many. POTS being another one, postural orthostatic tachycardia syndrome. And I think that there's just the most important thing being that if there's a research and clinical and advocacy approach, that's a big tent coalition building exercise. That's the best way to advocate for these diseases and to get them solved.
So are you saying that the treatments or the therapies for all of these diseases are the same?
Yeah, well, symptomatically, a lot of the symptoms are.
The symptoms are the same. What about treatments?
Depending on the pathogen, it might need a different treatment to look at the underlying infections of for Lyme. Antibiotics is one of many ways to treat. If not the primary way, and then so for COVID, antivirals would be more prevalent. But for the immune disturbances long term, then yeah, some of the same drugs would be in play.
What at the end of reading your book, what would I know that I don't know now, and what would I understand that I don't understand now?
That the global long COVID patient community is, I would argue, the tip of the spear for how this larger sea change and how the healthcare system can adapt. I think that's a core insight of this book. It's a core insight for all global health leaders and political leaders around the world, that there's a long-term onslaught of disability waiting many of these government systems. And if they listen more closely to the patient voice, and if they create research systems that are directly engaged with patients and put patients in the driver's seat, I think there's an approach here, not just for solving long COVID, but for solving basically any disease that direct community engagement is.
But there's a clash there between doctors who want to give you 7 minutes and prescribe what they know, and therefore diagnose what they know, and people who suffer from myalgic encephalomyelitis or long haul or severe Lyme disease, who need a lot of time to explain their situation to the doctor. It seems to me that the pressure on doctors to see more patients, to see them in briefer periods of time, is really very damaging if you have ME or a similar disease, that it takes a lot of time to explain, a lot of time for the doctor to watch the patient, a lot of time for the doctor to establish an empathetic relationship with the patient. These are important parts of medicine. I think that's what Osler, the great physician who founded Johns Hopkins Hospital, he said you had to listen to the patient, you have to watch the patient. But modern medicine, it has to go through a sea change, because the patient is getting less and less attention, and more sort of prearranged prescription medicine, where if you have X, and Y as symptoms, you must have Z, but it doesn't follow that you have Z at all. And I think there's a great desire by doctors to prescribe and diagnose, as I said a bit earlier, what they know, not what they find out. How are you dealing with that? Is that in your book, and what is your personal experience?
Yeah, a lot of that, those arguments are in the book, and one of the core needs there is to develop diagnostic markers so that this I'm a huge advocate for empathy. I'm a huge advocate for listening in the way that you talked about with Civilian Osler. But in the end, I mean, getting to a point where these are easily diagnosed with objective biomarkers that the modern industrial healthcare system can understand, that's a core goal for how the research agenda should move forward.
What about what biomarkers identify ME besides fatigue? When you go to the doctor and you have headaches, you have aches everywhere, you have brain fog, you have unresolved fatigue, you sleep and you don't feel better, you are you're in trouble, you go to the doctor. You are not, though, able to present any biological markers. Bodily fluids don't do it, and the doctor has to take time and do a wastebasket analysis before the doctor finds out what it might be, if it is ME or long haul or something else. Now, if it's long haul, there is a clue, because there obviously was a time when you had COVID, and so you can trace it back to COVID, but with ME, you can't trace it back to anything. And with many other diseases, you can't trace it back to its origins, to the initial assault. And how does that work if you're industrializing medicine, which is a subject I think that deserves, and I'm glad you wrote a book, because it deserves a lot of attention.
Yeah, and it's important to push back on the idea that tests are normal, because for experts in ME and long COVID, there's no shortage of things that come up abnormal, and natural killer cells being one of the key ones that could end up being like the biomarker, where it certainly is a marker for a number of patients right now. T cell exhaustion, cortisol abnormalities, cytokine expression can be elevated in a number of measures. there, and obviously you can have Epstein-Barr reactivation, and you can have persistent traces of the viruses that could be found in tissues. So those are all important, and there's a long list of other abnormalities that are useful for diagnosing this at a deeper level. So getting those markers, those tests available for more patients is an important part of this. And one of the key new areas of research that I discuss in the book is around microclots, which small clots in the blood that have been found by researchers in South Africa who were looking at long COVID. And originally that work was going to be done in the CFS, but they ended up doing some pilot studies in long COVID first. But that research should also be introduced into the ME/CFS community as
Ryan,
well.
I didn't quite get that. What is it that is found in the blood?
Microclots. So a small blood clot. Blood
microclots. Okay.
Yeah, a clot that's not in this particular type of blood clot is being detected with a technique called fluorescent microscopy, and that is not a device that's around in many clinics, in many hospitals. So it's a specialized test that has a specialized marker, but that's been a pretty useful pilot study. And I think if that was scaled up, I think if the NIH funded that type of work, there's a potential that the results could come from that. And those researchers who are doing that work in South Africa and in Germany are finding that using a dialysis technique to clean the blood, it's called HELP apheresis. They found good results that clear out those blood clots and then bring down symptoms from the patient in accordance with the clotting scores go down, the symptoms go down. And now I don't know if this particular test and if this particular treatment is going to end up bearing fruit for millions of people, but it's one of the key areas of research that at minimum it certainly shows that it's biologically objective and demonstrable. But really what we're after is a quick diagnostic for all patients and then immediate treatment for all patients.
What is the book called, Brian?
The book is called The Long Haul. It's solving the puzzle of the pandemic's long haulers and how they're changing healthcare forever.
And it is available on what date?
November 15th.
And tell me, is it available on Amazon, Kindle, and all of these platforms?
Yes, it'll in bookstores everywhere, November 15th. Amazon, Barnes and Noble, on down the list, and then the Kindle version just went up in the past week for pre-order, and the audio, I'll be going into the studio next month to record the audiobook, and that'll be out.
And you're going to do that yourself, the audiobook?
Yeah, that'll be through Recorded Books, and that'll be available on all the.
Have you recorded a book before?
I've been doing some practice. And,
more power to you. I admire people who record books. It's a lot of concentration. Friends of mine do it. I wouldn't endeavor myself. I'm not a very good sight reader. I'm too dyslexic.
I think you've got a great voice, and I think you ought to.
No. Let's move on. Let's move on and talk a little bit about Ryan Pryor. When I knew you before, you were pretty well in the grip of ME. You were taking 19 pills a day. Are you still taking 19 pills a day?
Most days, yes.
And what is
a similar protocol? Yeah.
What is it's for somebody with ME to be able to hold a job and then write a book. This is close to a normal life. How long have you been able to live what is essentially a normal life?
I mean, I have dips, a few weeks out of the year, I may be down and out, and then I have to take a lot of these medicines to stay up. But outside of that, when I was with CNN, I was working 40-hour work week and traveling and exercising as much as I could, and so for aside from my first year being sick as a junior in high school, and then eventually getting a good doctor by the end of my senior year, I've probably I've had my issues, but I've can appear normal to them.
You were working on instructing or bringing doctors into ME, into this field of practice, which is very important. Everybody I talk to is in this field because they know someone, not because they were in medical school and said, that's interesting, I'd like to learn about that, I'd like to help there, I'd like to study that. Almost always it's, they will say, someone in the family, a close friend, which is, of course, how I came into it, through a close friend. The advocates also are the product of families and close friends. There's nobody seems to come to study ME or its related diseases, and I include, I'm not sure about long haul because it's rather new and different in that sense, although symptomatically it's identical. But nobody is leaving medical school to pursue this. I know a young doctor, a very gifted young woman, who is leaving, just finished her residency. She wants to do infectious diseases. And young doctors, I always find, already have a very good idea. You were working on a program to try to draw attention to the need for doctors in this field. How did that work out?
We were able to implement this program, which was called the Blue Ribbon Fellowship Program. That was in the summers for students between their first and second year of medical school, and that was originally designed as an 8-week internship program that had a clinical and a research component, and we partnered with Dr. Nancy Klimas at Nova Southeastern University, and we had a handful of students who've gone through that program and who received funding through the nonprofit I had founded at the time, which is called the Blue Ribbon Foundation, and we transferred that program over to being run by the ME Action Network, where I'm on the board of directors. And our hope is to continue working on that program, not just with Nova Southeastern, but to expand it to other schools. And it got a little tricky during the pandemic. So
tell me, how do you work?
Yeah.
I'm always interested in how writers write. I'm a journalist. I'm not a writer in that sense. I write in desperation on deadline. Like all, take our deadlines away and we wouldn't do it.
Coffee, anxiety, and deadlines. Yeah.
We didn't. But if you're writing a book, you better have some discipline. Do you write for 6 hours a day or 2 hours? And how do you marshal all of the material?
Yeah, the goal. This was a pretty scientific book, so there a lot of reporting from patients, a lot of interviews with experts who were clinicians or scientists or policymakers in different stripes. And the goal, the manuscript was about 75,000 words, and I had about roughly 5.5 months to put it out, to get the draft together, and so that based on the number of working days I had, the goal was to get about, I wanted to do 1,200 words a day, and I backed off that to 800 to 1,000 words per day. There were some days when I got that done in 4 or 5 hours, but some days it took 10 or 11. And I had to take some breaks, to take some long walks by the river to collect myself and brainstorm.
You still live in Atlanta?
Mm-hmm. Yes.
And where do you go from here? Are you going back into television work, or are you going to write more books? What does the future hold for Ryan Pryor?
I enjoy doing this sort of, I was a features writer for CNN, and so this magazine style, longer form articles has been attractive to me. And a role that I may take is a think tank related journalist in residence role via the Century Foundation. And Century Foundation is a DC think tank. They have a vision for how ME/CFS and invisible illness and long COVID build up into this larger umbrella of disability, which is in disability rights is an important aspect of human rights.
Writing this book, researching this book, the writing is not really such a large issue. It's the research, getting it all together, organizing it. What did that cause you to think about your own disease?
Yeah, well, one of the core insights I think for my own self is that I had spells when I had exacerbations of symptoms or relapses or crashes that would last for a few weeks. Frequently, I had those crashes in January 2017, January 2016 and 2017. I had big crashes, and I was on short-term disability from my job at CNN. And similarly, I got long COVID. I got several months of illness from COVID, also in January of 2021. And my thought was that my crashes probably correspond to seasonal flu in previous years, and then COVID just being quite a bit more powerful than the flu. Even though I don't have like horrible respiratory symptoms from the flu or COVID, because I have a low natural killer cell function, at least the idea in my head now is that, yeah, a lot of my crashes are probably directly related to viral infections.
Do you feel that you have any long haul, or are you actually still fundamentally a myalgic encephalomyelitis patient?
One of the chapters in my book discusses my experience getting COVID Christmas Eve of 2020, and I was on disability for a couple months after that, so that I wasn't able to work full time, and that caused exacerbation of this overall, it's an infection activated chronic illness, whether that illness be that infection be SARS-CoV-2 or other things. So I think that ME/CFS, or is someone a ME/CFS patient or a long hauler, overall what they are, it's a human being with a chronic illness and with an underlying immune abnormality.
Do you see any hope for ME sufferers? Do you feel all of this research and the additional money that has come into it as a result of COVID will speed up that glorious day when ME patients can be diagnosed and treated, not kept under glass in a hopeless state of neovegetation, which is true of some. I've seen some truly terribly afflicted people.
Yeah, I see some hope, and that was my inclination early on to write this book, when I was getting messages from the patient community in February and March of 2020, and we all saw this. There's a huge burden on the horizon. Tens of millions, if not hundreds of millions of people getting long COVID. On the other side of that, this was before we even knew the word long COVID. I just knew that something bad was going to happen to a lot of people who got infected with the novel coronavirus. We just didn't have a word for it. However, on the flip side is equally true, that a crisis is an opportunity, and there's enough of I think changing hearts and minds in the medical community that I think that there's a real possibility for change.
I have found enthusiasm in the ME community for the new money, for the new research, for the new sense of urgency, for indeed the new direction. But I wonder myself whether this won't sideline ME yet again, while people chase off after diseases that are more widespread and better recognized, like Lyme, like long haul.
Yeah, a core component of the advocacy strategy is to make sure that ME/CFS is, as much as possible, gets included and gets counted in these larger initiatives. And some of that, some of it gets lost. There's a real issue with a lot of the long COVID research, reinventing the wheel, doing fairly obvious studies, doing long-term observational studies when when there's clearly like good ME research that could be ideas from ME that could be directly injected into.
Are you saying there's a danger that research gets stovepiped?
There's a danger of
Siloed is another way of saying it.
Yeah, that's definitely an issue, and just in a lot of my reporting across all of healthcare for the last several years, COVID and rare disease included. Yeah, stovepiping and siloing is never not a problem, and figuring out how to design collaborative research networks and getting hundreds of researchers all on the same page in real time is always key.
Before COVID, we had this rather unhappy situation where when I went to the National Institutes of Health and asked them about funding, they'd say they didn't have enough proposals from the medical community, and in the medical community they were shouting for funding, so there was a huge disconnect. Has that been resolved? I mean, if that was true of ME back then, it must be much more true with long COVID, where you basically have a fairly limited, a finite number of researchers all chasing the same thing. Now, apparently they can get the money. Has this changed the dynamic?
There's some, a long list of kind of weird kind of chicken or egg problems with NIH about are there enough proposals, is there enough interest, and it's always true that if you have more money, then you'll have more proposals. That would be the side that I would take in that debate. However, in order to generate quality proposals, there's a certain amount of like growing the field that does have to take place. People will always go where the money is, and it's a big problem that if you're researching ME and you can't get funding, and if you're trying to raise your family or keep a roof over your head, it doesn't make any sense to stay in the field if you can't fund the work.
Let's just have the name of your book again, because that people should be reading this book when it comes out.
Mm-hmm. The Long Haul, Solving the Puzzle of the Pandemic's Long Haulers and How They're Changing Healthcare Forever, available November 15th.
Ryan Pryor, you're an extraordinary and gifted person. Thank you so much for spending time with us here on ME CFS Alert. The best of luck to you. Cheers.
Thank you so much for having me.